medical student at Emory University School of Medicine, and I'm one of the co-directors of STAR, along with Barrett Sanders, who is a medical student at the Medical College of Georgia. We want to give a warm welcome to you all to our second annual STAR Trauma-Informed Care Conference. STAR, or the Student Taskforce on ACEs and Resilience, is an interdisciplinary network of health professional students from institutions across the state of Georgia. We are dedicated to equipping the next generation of health professionals with the knowledge and skills needed to improve the care of people impacted by ACEs or adverse childhood events. We want to start off by thanking the people who made this conference possible. We are extremely grateful to Resilient Georgia for sponsoring this event. Please visit their website at resilientga.org for more information on how they are establishing and supporting ACEs and resilience initiatives all over the state of Georgia. Today will be filled with outstanding keynotes, interactive workshops, reflection sessions, and more. All of these sessions are focused on increasing our awareness and practical skills in addressing trauma and resilience across systems of education, criminal justice, healthcare, and advocacy, with a deliberate focus on the implications of racism and social injustice on ACEs and resilience. We are excited for an incredible lineup of speakers and workshop facilitators who are experts in their respective fields. And thank you so much to all of our presenters for sharing your time and wisdom with us today. We were blown away by the response that we received when we marketed this conference. As you can see by the map that we'll share on the next slide, our attendees are signing in from all over. Though the global pandemic has brought immense difficulty to a lot of people, we are really grateful for the silver lining of our conference being fully virtual and open to numerous people we would have never reached otherwise. We hope this will lead to fruitful new connections and networking. So please feel free to rename yourself in Zoom to reflect your institution and affiliations, and reach out to one another in the chat box to discuss further and connect. We are humbled and grateful for you sharing your time with us, and hope you'll continue to engage in STAR initiatives as we take the momentum of this conference forward. Finally, I want to thank our volunteers and STAR advisors for all of your support throughout the whole process. Though most of us have never actually met in person, we have been able to work together across distances to pull this wonderful event together, which has been such an amazing experience. And with that, I just want to go over a few reminders. So recordings from today's session will be shared via email after the conference. There are no pre-approved CEUs, but if you want a certificate of attendance, please reach out to Carrie Oliver at coliver@student.gsu.edu. Our IT team will move all participants and speakers to your respective breakout rooms, so you can just sit back and relax. Just remember to return to the main room at the end of the day for today's training scholarship drawings. We have some really great awards for future trauma-informed trainings and resources that you have the opportunity to win. If you are not able to select your workshops in advance, you will be randomly assigned to a workshop. But don't worry, because we'll be recording all the workshops so you won't miss out. Please keep your microphones and videos muted until the speakers begin interactive portions so that we can keep the meeting venue respectful. If you have any questions throughout the day, you can write them in the chat box or private message me. And without further ado, I will turn it over to our incredible conference director, someone who has poured endless time and energy into making this conference possible, and all while pursuing her doctorate of public health degree at Georgia State University. Please welcome Carrie Oliver.
Thank you, Eudora. So good afternoon, good morning, or good evening, depending where in the world you are joining us today. I have the pleasure of introducing our keynote speaker for today, Dr. Sarah Vinson. Dr. Vinson is a physician who specializes in adult, child, and adolescent and forensic psychiatry. She is the founder of the L'Oreal Site Group and L'Oreal Forensics, which provides mental health practice and services and expert care and consultation here in Atlanta, Georgia. In addition to providing mental health care services such as psychotherapy, consultation, she also is an associate clinical professor of psychiatry and pediatrics at Morehouse School of Medicine and an adjunct faculty at Emory University School of Medicine. I will now pass the floor to Dr. Vinson. Thank you so much for joining us today, and we look forward to your talk on social justice and pediatric healthcare.
All right, always good to unmute yourself before you start talking. So as she said, I'm Dr. Vinson, and I'm really excited to be here today and share with you about structural trauma and child and adolescent mental health. And I realize there's a little discrepancy there, right? The program says social injustice in child and adolescent mental health. And hopefully what will be apparent by the end of this talk is that there are really two sides of the same coin, and that when we're talking about social justice or a lack of social justice, what comes as a result of that is structural trauma that impacts children. And we will make my prepared comments around 30 minutes, hopefully, so that we'll have about 10 minutes at the end to speak. But this is an issue that I've seen firsthand as a first generation physician and an underrepresented minority, but then as a provider who's worked in public sector areas in Atlanta throughout my time here, these issues of inequity and how they impact how people present in clinic, the options they have to get treatment, and what I'm able to do to help them, and how that needs to look different depending on what the drivers are. And I actually recently co-edited a book, Social Injustice and Mental Health, with Dr. Ruth Shim at UC Davis. And when we first pitched the book to the publisher, the name of the book was supposed to be Social Justice and Mental Health. But as we did all this reading and writing and editing, what became very apparent to us is that the story of American society actually is not one of justice, it is one of injustice. So we went back to the publisher and asked them to change, because as we wrote about these things in the book, it was really a book about structural trauma and how it impacts children, particularly those from marginalized communities. And so we'll talk about structural trauma and child and adolescent mental health, and this will really just be an introduction, and hopefully will spur you to do additional reading, because there's so much and we have a relatively short amount of time. So I don't have any disclosures pertinent to this talk. I see that we have people literally from all around the world here, which is great, but I'm going to tell those of you who aren't familiar with Atlanta about two zip codes. One is 30307, which is where my private practice is, and one is 30331, which is where the public sector health clinic that I work in with my residents from Morehouse is located. And so we'll think about some special considerations as it relates to this topic, with an emphasis on poverty, housing, and education. Now, these topics can span things like immigration status or immigration policy, of course. So this is not going to cover all of the things, but these are the things that we're going to spotlight in this talk. So when it comes to kids, when you are rotating through your clinicals or as you're taking your classes, if you've worked with adult populations first, one of the things that will often be said is that children are not little adults. And so one of the things that is really interesting when it comes to children is the discrepancy between the narrative about how our society values and prioritizes them and the reality of where dollars are invested and resources are invested. And before we started working on this social justice and mental health book, my co-editor and I were talking about another project where we were talking about policies that have been helpful to different groups of people. And she wanted me to write about a policy that's been really, really beneficial to children specifically, and CHIP was already taken, the act that helped kids get healthcare coverage. And we went back and forth a while about how there really aren't a lot of things that differentially impact children in a positive way, because they're just not a population that is prioritized by our lawmakers. And so when it comes to kids, when you're thinking about social determinants of health, and social determinants are mediated by social structures like the housing system, the healthcare system, the educated system, that the child and adolescent mental population is uniquely impacted by these social determinants. It's a population that is by definition legally dependent, be it on a family or a child welfare system, to make decisions about how their basic needs are met. And they don't have control over significant resources and are unable to independently enter into leases for housing, go grocery shopping, or even consent for treatment. So things that we know matter, like whether you live in a food desert or a food swamp, are impacting children, and they don't have any control over where they are. Additionally, youth are physically, cognitively, and emotionally immature, rendering them susceptible to abuse and exploitation, limiting their means to support themselves financially, and undercutting their ability to skillfully navigate social situations and societal structures. So this is a population that is going to be disproportionately impacted if the social safety net is not in place, and by things like poverty. And we'll talk a little bit more about that later. And the last thing, since we are putting an emphasis on schools, is that children are often subject to compulsory education, which means that for most of them, they have to be in school, and the majority of their waking hours during the week are in a school setting. So this is a system outside of their family that has a tremendous amount of influence over how they see themselves, how they see themselves in the world, even apart from the educational mission or curriculum. So for those of you who are sort of not sure what structural trauma means, or you're unfamiliar with that phrase, one way to think about it is when society systems and structures, governments, economy, safety net services, as they are configured and routinely operate, are instruments of harm to a child's developmental process or mental well-being. The thing I really want to point out here is that this isn't some disaster. This isn't a hurricane that comes and goes. This isn't a mean person who harms a child intentionally. This is business as usual in the society. And when the systems as usual in a society do things that are harmful, that is structural trauma. And it doesn't get as much attention as some of the other adverse childhood experiences. It's harder for people to sort of wrap their minds around, especially if they haven't lived in communities that have dealt with these things. But I would argue that because of how persistent it is, because of how pervasive it is, because families, communities, children aren't able to escape it, that these traumas are actually some of the most significant ones, even though they don't enter into the national consciousness or a lot of these conversations about trauma. And even if you look at something like the 10-question ACE questionnaire that is often discussed and that has really made its way into healthcare, not just mental health care, where you get 1 point per thing, it really doesn't ask about structural trauma, but we know that structural trauma is something that negatively impacts people and children. So I know that we have a mix of people from looking at the chat, but one of the things that comes up when you start talking about societal structures and people's trajectory and how they do in life is this Marshmallow Experiment. And I was actually at a psychiatry conference where someone was talking about social determinants of health, and this psychiatrist got up during the question and answer period and said, well, you know, the Marshmallow study, like it showed that these people, that was the word, that was the way he said it, these people just don't have self-control. And, you know, they did this study with these kids, and the kids who were able to rate for the marshmallow did better in life than the ones who didn't. And it's just like, you know, a result of these people. So putting programs or putting money into programs for them is not going to make things better. And that is something that comes up often, especially in a country where there is this value placed on individualism and independence, that there can be this thought that people just need to make better choices or different choices, and it's not really up to society to address these things. And so we'll run through this study really quickly, but the first one, the one that that psychiatrist was referring to, was done by a psychologist named Walter Mischel in the 60s and 90s. It had less than 90 kids, and it was all children who are from Stanford's preschool. So this is a very select group of children. And what they saw is that the kids who passed, so who were able to wait for the marshmallow to get 2 at the end rather than taking it right away, seemed to have better success later in life. One of the things that even that original study author commented on was that helping kids wait was something that was teachable. So it wasn't this hardwired thing that these people just couldn't wait and have impulse control. And that there was also a relationship between trust in the administrator and people's willingness and ability to wait, and that there seemed to be some impact on the home environment. So this experiment was repeated later. And this test had more than 900 kids, 4-year-olds, much more diverse population, socioeconomically and racially. And what they found is that you did still see this thing where the kids who were able to wait seemed to do better in life when it came to education and that sort of thing. But the prediction went away once you controlled for family background and intelligence. So once you looked at the child's environment and what those meant about that child's experiences, the prediction went away. So it wasn't an individualistic thing. Even the Marshmallow Experiment was really about these social determinants, and that it tracked by mother's college experience and the consistency that child had in their lives. And even the original study author said the idea that your child is doomed if she chooses not to wait for the marshmallow is really a serious misinterpretation. And it came back to trust and security. So we know that when it comes to trauma, when you undermine somebody's sense of safety and security in the world, especially early on, especially over and over again, that is something that can be traumatic. And so by the numbers, if you think about safety and security, a really basic thing you need is food, clothing, shelter, and poverty. Poverty mediates your access to having those things and to having those things in a consistent way. I find that it's useful in talking to people who have advanced degrees or who are in the process of getting advanced degrees to have a little bit of a reality check about what a poverty threshold for a family of 4 is. They're often surprised at what that number is set at. So when we're talking about poverty or poverty numbers in the United States, it's helpful to know where we're starting. So the poverty threshold for a family of 4 is $25,750. So you can imagine that there are people who aren't going to be captured in these poverty statistics who are making $28,000 a year, who certainly don't have consistent availability of things that you need to help the children in your household feel safe. In the state of Georgia, and I know we have people from all over, but here we have 1 out of 5 children living in poverty. 17% have had past year food insecurity. And with COVID, what we've seen is that with people not having access to school lunches and school breakfast, and this is something that's been commented on across the country, that it's really laid bare how dependent many families are on that added support of food from school settings. And 40th is Georgia's rank in child economic well-being. In the state, we also have 23% of our 4th graders chronically absent from school. And I use this statistic because, once you get into 6th or 7th grade, people may think, oh, the kids are skipping or they're choosing not to go there. But at 4th grade, you're 9 or 10 years old. So this is, to me, a marker of family instability. And this is a significant portion of your population that is dealing with family instability that surely has other ramifications for them, but is also disrupting their educational process when they're really trying to get foundational building blocks that will carry forward for the rest of their schooling process. And so what you see is that the families who are facing these negative social determinants, the families that are facing this social injustice in their segregated neighborhoods or in their underfunded, forgotten about rural communities, have more of a demand for mental health services because we know that there's a correlation between not having what you need, the trauma of that instability and mental health symptoms increasing, while at the same time not having the access to care. So those same communities, underserved rural communities, impoverished, hyper-segregated inner city communities don't have the treatment providers or the access. So even if you have coverage, if you're in a state that expanded Medicaid, which Georgia is not, but even if you have coverage, if you don't have a provider who takes that coverage, then you're less likely to get help. And what we see is that even when you look at Medicaid, if it's a Medicaid neighborhood, if it's a neighborhood that is majority minority racially plus Medicaid, that number goes down even further. So what this leaves is families in the gap. So the proportion of homeless children under the age of 6 is represented here. And 30% of children under age 6 are in low income working families. And so there are these different systems that are entrusted with taking care of kids. And one of the most tragic things that I've seen as a child psychiatrist is when families have to give up their children, or when families' children are taken away from them because they don't have the monetary resources or the material resources to provide for their children. I have done forensic evaluations on children whose mothers were working full time, but because they didn't make a living wage, it wasn't enough to cover the basic needs of their household. So what you see is that this family's poverty becomes something that is in a way used against them to call the adults unfit, and these children are removed from their family system into the child protective system. And the child protective system has people who often are well-intentioned, but they are up against a significant structural barrier in that there's underfunding and there aren't enough people. And so this system that's charged with protection often introduces more instability into a child's life in terms of multiple placements, multiple caseworkers, and things like that. And there was one situation that was particularly striking for me, working in the same underserved community in Atlanta, where I've been in the past 5 or 6 years. And it was a family where these children have been placed with this woman who wasn't any biological relation to them. And it was a sibling group of 4 or 5 kids. And one of the older siblings had inappropriately touched one of the younger siblings. And so we had to talk to her about how we needed to talk to DFACS about this, or Child Protective Services about this. And before we even got to that part, though, part of our discussion in terms of the psychoeducation was that many of this child's presenting symptoms had to do with the fact that they had experienced trauma, because she thought he was bipolar and he needed to be on all these medications. And we didn't agree with that idea. And we're trying to explain this to her. And she didn't like that and sort of left the appointment abruptly. And so I, as a mandated reporter, need to call and make this report about what's happening with this older child in this household. But I don't have all the information because she left the appointment prematurely. So I called DFACS and I give them the child's name and the child's date of birth. And I say, you know, this is a child who's already in custody. And she says, well, what is his address? And the person's name was Ginger. And I said I wasn't able to get it because the woman stormed out and she got here for the appointment late, so the front desk staff didn't get all they needed from her. And I said, but this is one of your children. This is a child who's in DFACS custody. She's in your care. And she said, well, you know, even when they are, we don't always know where they are. So this is an agency that's taken children away from their family and they're supposed to take care of them and they don't even know what their address is. And this is what these children are being exposed to and experiencing. So how many children are in foster care in the state of Georgia? And that number is 13,873, which is a really significant number. And what we also experience here, as is the case in many places, is that we don't have sufficient caseworkers. So our DFACS caseworker annual turnover rate is 29%. So what this means is there's a lack of continuity in that child's life when they've already had a separation from a primary caregiver. And now this person who's supposed to help them through the system and usher them through all these changes is also somebody or something that's changing in this child's life. And so how might this impact the services that these families receive? And if we were in person or if I had more time, we would have a conversation here. And also thinking about what implications that would have for children's needs being met. And so this is the story, and I've changed the name of Susan, and she was a mom who had dual diagnosis of bipolar and substance use disorder. And her child was taken away after she was incarcerated. It was briefly, she didn't go to prison. She was arrested, was able to get out, but the child was removed from her home. And the requirement from the agency was that she undergo a battery of tests, which she did. And she received verbal recommendations around therapy and the things that she should do. And the mother was doing the things that had been asked of her, but her caseworker changed midway through. And so then the mother, who had been checking off all the boxes, doing everything asked, really motivated to get her child back, ended up waiting months for her caseworker to be reassigned for her. Those assessments that she went, that whole battery of tests, somehow got lost in the shuffle, and she started to experience hopelessness and feeling like it didn't matter what she did. She wasn't going to get her daughter back, and overwhelmed by how unfair this all was. And she relapsed, and then she had to restart that entire process all over again. And that's a situation that's traumatic both for the mother and for the child. And so what we see is that these social determinants, poverty, education, that they are a mediator for these other things, right? So if you are impoverished, you have less options over where you can live. You have fewer options about healthy food choices. You may have longer wait lists if you need medical care or mental health care. And we know that all of those things, nutrition, safe neighborhoods, early intervention, are things that are protective. So this has implications for how children growing up in instability or who have experienced trauma view relationships, and also how they think about authority. And this is something that's come up a lot in the wake of the renewed national emphasis on social justice and police brutality. So this may have been something that was jarring to some people, but for kids who live in neighborhoods where they see this all the time, this is something that was not a surprise to them, right? So think about what it means to be a child and told to trust adults, told police are your friends, told police protect you, and see these things taking place in the neighborhoods where you live against people that you love. So that ends up impacting your relationships because it's really hard to know who to trust or authority because you see people abusing that authority. It can have implications for maternal mental health. So we know that as the mother goes, often that's the way the child goes. And so if the mother is not adequately supported, doesn't have the things that she needs, isn't able to get nutrition, that's going to impact how she does. And there's the absence of that safety, stability, and nurturance that we know is essential for healthy growth and development. And then as a determinant, we see and we have lots of data to tell us that there are implications for emotional regulation, so your ability to feel anxious without feeling like the world is really going to cave in on you or that you're really going to die, or feel sad without feeling as if the whole floor has gone from beneath you. Resilience, so your ability to come back after you've had some sort of setback. And it also has an impact on your stress and immune systems. So this isn't just a matter of depression and anxiety, it also has implications for how people's physical health does as well and how they progress through life. In terms of their brains, we know there's impact on their developing brains, that there's hormones that are around at levels for extended periods of time that have negative implications for them. And you can see where this impacts the prefrontal cortex and their fear responses as well. And so going back to those neighborhoods that I told you about, that 30307 and the 30331. And so in 30307, the family median income is $132,000, and the family mean is $201,000. In 30331, the family median is $47,000, and the family mean is $70,000. So you see there's a really significant discrepancy there in terms of income, and these neighborhoods are maybe 6 or 7 miles apart. So I'll have medical students or residents come to meet me at my private practice office sometimes for supervision or for meetings. And what I'll often say to them is there is street parking available and a number of nice restaurants and coffee shops within walking distance. But when they come to rotate with me at the county clinic, I tell them it's in a food desert, bring your lunch. So just based on what I've told you about income and what's in walking distance and whether it's a food desert or not, you can probably guess the answers to these questions. Which has the highest graduation rate? So these are for the high schools that these two zip codes are zoned for. So based on that, if I ask you these things about the high school, you can probably guess and get it right. Which has the highest graduation rate? Which has math and English proficiency scores of 16 and 9% respectively? Which has 99% free lunch? Which has the highest student-teacher ratio? Which has a 73.4% graduation rate? Now that last one is the one that you might not get correct. And we'll come back to that. But first, I want to take a bit of a diversion. So Dr. Jeff Duncan Andrade is an educator, reformer, leader in the Bay Area. And he talks about the difference between schooling and education. And with schooling, you have a system that perpetuates extant social hierarchies that basically just prepares kids to stay in the place they're already in, that it's not meant to be actually transformative or something that is empowering to them. Whereas education is something that allows people to realize their potential and improve their station. And he makes an argument one that I think is a compelling one, and other people have made it too, that the American education system is actually an American schooling system. And you'll see why we say that on the next slide. But to take a quote from Dr. Jeff Duncan Andrade, if you want to oppress people, you don't deny them school because they'll get educated. Instead, you school them. You take their children for 13 years and you create a system of passivity. Everything that comes out of that system is going to be a social mirror. So even though the graduation rate at Booker T. Washington High is 73.4%, and this is the neighborhood that is zoned for the lower income community, only 34.5% of their graduating students are college or career ready. Compare this to Druid Hills High, which is the high school in my private practice zip code is zoned for, where those kids come out 77% college or career ready. So these children have done what you've asked of them. They've stayed in school, they've stayed out of trouble, they haven't gotten arrested, they followed the things, they've gone to the place that you made them go for education, and when they graduate, only a third of them are ready for the next step. These children are being placed on a trajectory that is going to keep them in that place in the social hierarchy.
There's this phrase that you might hear in the news sometimes, the school to prison pipeline. It's shorthand for how schools are funneling students, especially Black students, into the criminal justice system. It started in the 90s when schools responded to fears about crime with zero tolerance policies, which mandated suspensions and expulsions for certain violations. They also cracked down on little things like talking back or uniform violations. The hope was that it would keep bigger problems from bubbling up. But as a result, out-of-school suspensions have doubled since the 1970s, and they keep increasing even though juvenile crime rates have now been dropping for years. Around the same time, the number of police officers stationed full-time inside schools has increased by a third between 1997 and 2007. Ostensibly, they were there to prevent mass school shootings like the one at Columbine, but they end up being a way for schools to basically outsource discipline to the police. Schools with officers have 5 times as many arrests for disorderly conduct as schools without them. Sometimes the results are shocking. But the less visible effect is that schools are feeding the racial disparities in the criminal justice system. Consider the fact that schools are more likely to have an officer on their campus if the student population is more than 50% Black. You might assume that that's because there's more crime at these schools, but although students at police schools are more likely to be arrested, they're not actually more likely to be charged in court for weapons, drugs, alcohol, or assault, at least according to one study. During the 2010-2011 school year, 1 in 6 public school students in the US were Black, but they accounted for 1 in 3 arrests at school. Same goes for other forms of school discipline. Black students are suspended or expelled 3 times more frequently than white students. It actually begins in preschool. 18% of preschoolers are Black. But if all preschoolers suspended more than once, 48% are Black. Studies show that differences in behavior can't fully account for these disparities. Black students and white students are sent to the principal's office at similar rates, but Black students are more likely to end up with a serious punishment. One study found that white students are more likely to be suspended for provable offenses like smoking or vandalism. Black students are more likely to be suspended for subjective offenses like talking back or insubordination.
And one of the things that is striking to me about that video is when that officer is attacking that girl in the desk, the student behind her barely looks up. So that's an indication of how commonplace seeing things like that are for her, that she wasn't even shocked by what she saw going on. And so when we think about the school to prison pipeline, which is what that was discussing, it also speaks to where we put our resources and which kids we see as redeemable or whose pain we acknowledge or recognize. So there are millions of American children in schools that have school resource officers and not a single nurse or counselor or therapist. And we know that children often externalize mental health issues, so do adults actually. And the school resource officer is going to have a punitive response. It's going to likely make things worse. But they don't have any of those supports or those things in place because we've chosen as a society not to put those people in place consistently in school settings. And so when we're talking about the school to prison pipeline, specifically as it relates to racial disparities, we know that there is a large literature showing that Black children are thought of as being older, and they're not given the same benefit of the doubt when it comes to innocence or being youthful, even though, of course, they are children too. And there's a way that a piece of this goes back to just sort of the national consciousness around Black people and their humanity, and Black children not being as worthy of protection, because if we think about the origins of this country, then if they were, then that says things about America that we don't like to think are true. But so those are things that carry over into preschool, into school discipline. But then there are also implications for access to treatment because these social determinants disproportionately impact Black and Brown and Native American youth, who are often left out of the conversation. And so you don't have as much access to diagnosis and treatment, but what we see is that because society is primed to think of Black kids as bad, that mood disorders and trauma is often underdiagnosed in them, and things like oppositional defiant disorder and conduct disorder are diagnosed. So there's a way that there's a synergy between the structural trauma in the school system and what happens in the mental health system as well, because of the structural racism that's there. And as a practicing psychiatrist, this actually impacts my informed consent process that I have with Black children and my anticipatory guidance that I have with them. In my private practice clinic, I don't have to worry about kids being asked to empty their pockets or them being interrogated by police officers without their parents there. In my public sector clinic, I absolutely have to worry about that. And those are things that I end up talking to kids about, what you have to tell a cop, what you don't have to tell a cop. And it's part also of my informed consent process with mothers around the reality that society gives their children less room for error just because of how they look. And so this can impact how kids show up. And so there can be different thresholds for presenting with things like depression or anxiety. And there are also implications for what is available for treatment, what kind of formularies you have from a medication standpoint, and whether there is the ability to get high quality therapy. And something that's really important to point out is differentiating between what may be hopelessness because of trauma and diminished agency. So if I live in a neighborhood where things that are unfair happen all the time, every day, then what's the point of any of this? Versus it just being depression, and anxiety versus fear. So with anxiety, there's some distortion about what's wrong. There's some overestimation of bad things happening, whereas with fear, you have a reality-based concern. With suicide, we know that sometimes children who have experienced trauma can have a foreshortened sense of future. So it's hard for them to see themselves being 20 or 30 or 40 years old because they've seen so many people die early. And of course, this has implications for people's buy-in to school. And what I see when it comes to suicidality is it's often not so much about wanting to be dead, but about not wanting to live like this. And if you're in a situation where you don't see a way out, where the adults around you haven't figured out a way out, because the systems make it so difficult, that can contribute to suicide rates. And what we're seeing is suicide rates climbing in Black children. Protective factors are things like having connections, family support, religious involvement, academic success, and supportive peers. And then aggression, right? So this externalization of mood states and how that can impact how people see what they're going to do or be when they grow up, or even if they think they're going to. And also how safe children may feel when they're treated or medicated. I'll just go through one of these examples for the sake of time, but there was a young man I saw who kept coming into the hospital, would take his medicine when he was there, the psychiatric hospital, no problem. Go out, stop taking his medicine, get in fights, come back into the hospital. And I was just like, hey, what's up when you go home? And he says, well, on the street, when I'm off my meds, people know not to mess with me. He did not feel safe being adequately treated in his environment because he felt as if he needed to be on a hair trigger where he lived. And so with ADHD as well, there's a way that this can be a gateway diagnosis because it's common, but there are all these things that are affected by social determinants, like sleeping in overcrowded conditions, mom may be working overnight, hunger, lack of stability, difficulty with multiple moves, lack of appropriate educational accommodations, which we're certainly seeing now, that can look like ADHD, but are really more rooted in trauma. And not to say that the two are mutually exclusive. So thinking about taking action, hopefully this talk has gotten you thinking about the fact that we really have to support healthy development in all policies. So housing policy is a mental health policy. Education policy is a mental health policy, because it's all connected and you can't take one away from the other. This absolutely is your lane as a mental health professional or as a medical professional if you care about the well-being of children. Having curiosity about communities and striving for structural competency. So there's often this emphasis on Black people have stigma, and that's why they don't get care. And there's less of an emphasis on the fact that if you actually ask Black people why they don't get care, they tell you it's too expensive and they don't have insurance. So thinking about structural trauma and the systems rather than pathologizing or placing the problem in the underserved group, looking at the underserved system and understanding how societal structures are contributing to the inequities that you see. Having screening and resource awareness in the settings where you're working. So if you're a mental health clinic, still asking about housing insecurity and food insecurity and knowing what the local resources are. Partnership and collaboration is key. And then always lending our voice. And this was a woman who was in a clinic where I worked on that side of town that was zoned for the school that had the low career and college readiness. And in combating the food desert that was there, the clinic actually has a community garden, and they had vendors come in and sell fresh vegetables. And she talked about how her kids really loved the kale, even though they were skeptical at first. And so she ended up telling them that just they should eat it because it was collard greens. And so I just want to thank all of you for taking time out on your Sunday. I know you could be doing any number of things, but thank you for being interested and curious about this. And invested in advocating for children.
Thank you so much, Dr. Vinson, for that amazing talk. We will now open it up to any questions. So if you have any questions, you can feel free to share them in the chat. And then I will say them out loud so that Dr. Vinson can address it. Of course, we're getting just a lot of gratitude for what you shared today and the topics that you brought to light. So thank you again. So if you have any questions for Dr. Vinson, be sure to put them in the chat. Some people are mentioning that this was one of the best presentations they've seen on structural trauma. And also this idea that they are seeing a lot of the issues you brought to light, as you mentioned, across the world. So some people mentioned that they are seeing these same issues that you pointed out here in Georgia and New York.
Absolutely. And I did some work with mental health clinicians in Liberia, teaching with the Carter Center. And one of the things that was so striking to me was how trauma actually looks quite similar in terms of what it does to children in different, very different settings and places. So I saw that.
One of the questions
go ahead.
Yeah, one of the questions that was posed in the chat is there a specific reason why children of color are treated as if they are older?
Yeah, so there's this phenomenon of adultification. I see Dr. Clark gave that answer, absolutely, that Black children are thought of as less innocent. And there's this trick that America plays with itself on a mind level, right? That this is a land of the free and the brave and this great equitable society. But the reality is our entire economic system was based on slavery and on displacing and largely eliminating an entire group of people. And so with the Native American population, our society has in a lot of ways sort of just, they don't talk about them as much, but they're sort of left with these Black people who are a reminder of the fact that slavery and breaking up families and selling people was a part of this country's bedrock for their foundation. And part of how that has been justified with help from the medical and mental health community is this idea that Black people don't feel pain in the same way, that they are not as developed, that they are something like human, but not quite the same, and that these children who were being forced to work in fields, weren't being educated, weren't being protected, were ripped away from their families, were somehow like more sturdy or more resilient. And that has carried over in how we think about who's worthy of protection, and who we see as sort of innocent, because it calls into question sort of our national narrative if Black children are worthy of protection, and we as a country have actively harmed them at every single step along the way.
We have another question in the chat from a counseling trainee who asked, what theoretical orientations or interventions do you find most compatible with conceptualizing clients in a way that acknowledges and honors the impact of structural trauma?
That is a really great question. So I would say that mental health and medicine really has some catching up to do, that you're probably not going to find all of it in one place, that there's going to need to be some self-study around being able to do this work in this way, because a lot of the people who are coming up with the theoretical frameworks are old privileged white men. And so they don't necessarily have the lived experience or the motivation for thinking about it in these ways. And so understand that every theoretical framework you use can be used for this. There's a woman, Dr. Beverly Stout, who's based in Atlanta, who's a psychoanalyst who wrote about Black trauma and identity development, and how that impacts things. So it's not anything that is orientation for specific. It can actually span across them. And part of our job as mental health professionals is learning about these things so that we can look at them in context and also think about solutions that are in context. So I would say that in terms of sort of thinking about it as a first step, if you haven't read Helena Hansen and Jonathan Metzl's article about structural competency, that's a really good place to start, because it takes us out of that cultural competency sort of framework and says, let's go a step back and look at societal structures and how they impact these things too.
Okay, I see we'll take one last question before we have a little break before our first breakout session. So someone asked, in addition to seeing food deserts, are you also finding medical deserts where people, where are zip codes where there's higher poverty levels and resources are leaving?
Absolutely. So mental health professionals, like most professionals and most businesses, cluster in higher income communities. And I actually just wrote a paper about mental health care reform as a way of decreasing criminal justice system involvement of people with mental illness. And one of the things that I found, which wasn't surprising, but it was cool, well, not cool, but it was interesting to see a paper about it. It's not even just income. So if it's a low income white neighborhood where most of the people have Medicaid, they're more likely to have providers than a low income Black or brown neighborhood where most of the providers have Medicaid. So there's always that intersectionality piece, that being white and poor is not the same as being Black and poor, being white and middle class is not the same as being brown and middle class in terms of some of the barriers that people face and experience.
Okay, thank you for that, Dr. Vinson. So if you have a question in the chat that we did not get the opportunity to address, we'll be sending it to Dr. Vinson and we will get you a response in our follow-up correspondence. So thank you again for this amazing talk. So just so everyone knows, we will be moving into our first round of breakout sessions, and the topic there will be trauma-informed healthcare systems. So we have another round of amazing speakers, and those will start promptly at 3:05. So you can feel free to take a break, stretch if you like, and then we will begin those sessions. Thank you again, Dr. Vinson. We appreciate you being here today with us.
Just a reminder for anyone who may have come in a little bit later, please feel free to rename yourself in the Zoom session to reflect your institutional affiliation. You can go to the participants tab and click on the drop down next to your name to rename yourself. Additionally, we have a poll looking at where everyone's coming from today. So I'll repost that in the chat and you're free to fill out that poll so that we can see it on the map. Thank you. See you soon.
So we will be starting the breakout sessions in about 4 minutes. And as a reminder, you will just get a pop-up that will take you to your designated breakout room. No need to do anything else. So that will start at 3:05. So our workshop sessions on trauma-informed healthcare, those breakout rooms have now opened, but they will not start until 3:05. You can feel free to join the room as the pop-up appears for you to join it.
Hi, Dr. Gillespie. My name's Bharat Sanders. I'm from STAR.
Hi, how are you?
Good, how are you?
Good.
So I'll just be introducing you and then I'll hand over the floor to you. Would you like to advance
Okay.
your own slides or would you like me to share your slides for you?
I can do it. Yeah,
Okay, great.
yeah, I have it up so I can just get it started. Do you want me to pull them up now?
Sure, if that works for you, go for it. And then I'll introduce you in just a minute here and then we can get started.